Thanks again for joining us. We are excited to be here on the American Academy of Optometry Foundation clinical podcast series. Today, we are joined by Dr. Pablo de Gracia. It is fantastic to have you, Pablo. Thank you for joining us. Tell us a little bit about who you are and what you're up to these days.
I have been working for the last 15 years on the field of vision sciences. I got my PhD degree at the National Council for Research in Spain. And then I moved to the United States, where I have been working for the last 10 years. I was 3 years at the Barrow Neurological Institute. Then I worked as an assistant professor for 6 years at Midwestern University. And now I have been working for almost the last 2 years at the University of Detroit Mercy as the associate director of research and associate professor at Detroit.
Wow. Yeah. And, I've been a little bit curious about some things with regards to myopia management. I'm just kind of curious if we have any data about myopia management's efficacy of extended depth of focus soft contact lenses, particularly in Caucasian children. Maybe we have a 2-year result on that. We have a paper on that very thing, and Pablo is going to break it down to us. Pablo, why is this topic so important to optometrists? And, this range of depth of focus, extended depth of focus for contact lenses seems to be really a key component. Walk us through a little bit about the importance here.
Yeah, so basically, many of our listeners might already be very familiar with other contact lenses that are used for myopia control, like, for example, MySight lenses or previously the Biofinity lenses. But what is new about this paper is that they are presenting another lens that is called MYLO that has a completely different design. Meanwhile, the lenses that were used for myopia control with the MySight and the Biofinity had the adhesion on the periphery. The MYLO lens has mostly the adhesion placed on the center of the lens. So it is very interesting to notice how, even though the philosophy of where to position the adhesion for these lenses is completely opposite to what we were accustomed to, they still work for myopia control.
Yeah. Tell us more about the monthly soft contact lenses with extended depth of focus. Why is the MYLO lens? What is it? And tell us a little bit about how it was evaluated in this particular study.
Okay, so the MYLO lens is used in other countries because in the United States, it's still not, you cannot use it for myopia control here. It's not FDA approved, but for example, in Europe, they are using it for myopia control. So the major difference that you can find between the MYLO lens and other lenses that are already used here is the positioning of the ad. MYLO lenses have the adhesion in the center of the pupil. Meanwhile, MySight lenses, Biofinity lenses have the adhesion towards more peripheral locations. So it is very surprising to be able to notice that regardless of where the adhesion is located, all lenses seem to have the ability to control the progression of myopia in kids.
Yeah. Yeah. Why was, in this particular study, why didn't they do a non-randomized design? Is there anything kind of like stuck out here?
Yeah, so basically there has been so many previous studies in which it has been shown that myopia progression can be stopped by using multifocal contact lenses, than using a randomized study. It's unethical at this point. So
yeah. And to kind of put that, and this was discussed pretty in length at the Academy meeting this past year in the myopia management papers, is we know what the effect is. We've seen that data. We have the results, and to randomize children into a non-treatment group, we know what's going to happen. They're going to progress in their myopia. So we can use kind of a virtual subgroup as comparison, hopefully, for all the studies continuing on in the future and moving forward. Do you think that's typically going to be what we're seeing, is like this non-randomized group moving forward?
Well, hopefully, but I do have two persons inside of me because I have received training as an optometrist and also as a scientist. So as a scientist, it feels deeply that we still don't know how these methods work. As a clinician, I think that since they work, they should be used. So at this point, I think that the more fair treatment that can be given to patients is to give them the state-of-the-art care that has already been proven to work. So we should start using virtual control groups, because it seems unfair to say to a kid, well, we could stop your myopia progression, and you certainly are here interested in getting your myopia being stopped because that's why you are here seeing me. However, we are going to randomize you, and you might get it or you might not.
Yeah.
Another thing that it could be done is to reduce the size of the control groups, right? Even though the gold standard is a 50-50, it is quite unfair for a patient that is going to receive treatment and that they want to be part of the study because they want to get the treatment, to face the situation in which they only have a 50% chance of actually getting the treatment. So even though it is more costly, another avenue that could be had is to reduce the percentage of people that is getting the placebo in all this.
Yeah. Well, soft multifocal lenses, they seem to be a mainstay. They're not going to go away as a main emphasis in myopia management. One of the things that I always get worried about, and especially that I hear as a worry and a fear from other clinicians, and you can speak to what the study showed on this, is, when presbyopic adults are wearing multifocal contact lenses, sometimes they have a deprivation in their visual acuity, a deprivation in their contrast sensitivity, something along those lines. How did this affect kids in this particular study?
Well, in the study that we are reviewing, what it was found is that even though visual acuity was one line less using the multifocal contact lenses than using the single spectacle lenses, none of them, when they were asked subjectively, they were finding troubles with this lack of potential maximum visual acuity. They did not complain about it. So they were extremely satisfied with the results that they were obtaining, even though they could still get a line more of visual acuity by using the glasses.
Isn't that something? I mean, if we think about this from adults' perspective, and an adult potentially would really be frustrated by that. But it just goes to show, and this is my personal perspective on this, is when we're doing myopia management, our number one goal is to slow the progression of myopia, not necessarily to get the best line of acuity. Because in this case, the children, they didn't care. They didn't notice that it was a significant difference, but yet there was a clinical effect on them. So talk to us about, in this particular study, what happened to the refractive error changes and the axial length changes. That's really the nut and the bolts of why would you do this if you didn't see that?
Yeah, so in this study, they followed children for 24 months. And what they found is a difference of half a diopter in the progression of the refractive error for the kids that were treated with contact lenses versus the kids that were treated with glasses, in favor of the kids that were treated with the multifocal contact lenses. So they were less myopic by half of a diopter. They also found that the axial length was shorter for the eyes for the kids that have been wearing the contact lenses versus the kids that have been wearing the single vision spectacle lenses. And the difference between for the axial length was around 0.3 millimeters. You will expect that will translate to a little bit more of difference in the refractive error, but somehow a little bit of the potential gains that could have been obtained because of that shorter axial length was lost somewhere else.
Yeah. Fascinating, really intriguing here. And one of the other things, just in brief, and we could talk about this for a really long time. I love hearing your perspective, is that the subjects found the lenses to be comfortable. They had good vision, And they said they'd like to continue wearing them, right? And I bet their parents did too, because of the slowing effect that it had. Beyond that, anything we didn't touch on that you want to emphasize or any closing thoughts with regards to this? This is a lens from something you have back home. You're in the States now. I've heard about this lens outside the United States, and the American Academy of Optometry Foundation's podcast is not just heard in the States, but by and large it is. But this is a lens that's out there. It's out in the
Yeah.
world. I was in New Zealand. They are using it. It's all over the place. We just don't have it in the United States yet. Have you heard good things about it? What have you heard?
Yeah, so the design was originally designed by Brian Holden Institute and is now commercialized by Mark Enobi. It is commercialized everywhere but here. We know that we have the more stringent regulations that work for our advantage because we require that it's proven elsewhere before we can actually use it here. So that's very positive. I have always heard good things about the use of these multifocal contact lenses. And one thing that I have a question on my mind about them is that because the placement that they have for the addition is in a more central zone, it can actually modify more how kids accommodate. Because, and this is the reasoning, when you have a MySight lens, for example, they have the addition on the periphery, which means that if the kids are outside and they have a small pupil, they are basically not seeing at all this addition, and they basically are wearing a monofocal lens that allows them to accommodate as they would without a contact lens. But when you have this MYLO lens and you have the addition on the center, even if you have a reduced pupil, a small pupil, because you are running around playing football, you will still have access to this addition, and your ability to accommodate might be a little bit different. So that's one open question that I have about this lens that I will want to be addressed in the near future.
Yeah. Yeah, definitely some really cool things with regards to the science of how all of this is working. I'm excited for your insights and your perspective on it as time goes on. So thank you for being part of the podcast. It was awesome to have you.
Thank you so much, Dave. It
Yeah.
was great to be here with you.
Thank you. And thank you for joining us for the American Academy of Optometry Foundation Clinical Podcast Series. Make sure to check out other episodes, incredible scientists from all different aspects of eye care being part of the podcast series. We'll see you next time.